by NIH is really a big step forward. Mortality in women is still much higher than in men. And the very impressive fact is that this frightening finding was not the major point of this paper. It was a little side finding. And this really shows how gender or sex and gender aspects are neglected. Sex and gender differences are important for almost all disciplines in internal medicine. What we try to do in these EUGenMed projects is really to analyze the biological factors that are important for women and men, but also to include the socio-cultural gender dimension that is also very important for health and well-being. All the materials that we put out now, they need continuous updating and discussion and work on the implementation. And this is what we mean by sustainability.
There are different manifestations of acute coronary syndromes in women. For instance, Scott's sudden coronary artery dissections, which is a tear in a coronary artery, occurs more often in women. For instance, about 10% of all acute coronary syndromes in women below 50 years are sudden coronary dissection. If we look at elderly women, they have a higher cardiovascular risk profile compared to men, and also more concomitant diastolic heart failure. That's what we call nowadays HFpEF, heart failure with preserved ejection fraction. That means a stiffening of the heart. We see that more in elderly women, and that also affects outcomes after coronary interventions, such as bypass surgery. So if we look at the development of ischemic heart disease in women, we know that premenopausal women are at low risk. At older age, above 65, the risk increases, but there is a large gray zone between 45 and 65 years, where women have a low or intermediate risk, where we need to do better cardiovascular risk assessment. There is a feminine pattern of coronary artery disease. Of course, women have smaller arteries, and especially in the younger group, they have more spasm in the smaller side branches. Men have more, at an earlier stage in life, obstructive disease in the epicardial vessels. Women often have more a diffuse pattern of sclerosis. This slide on heart failure with reduced ejection fraction. Systolic dysfunction is more prominent in men, like peripartum cardiomyopathy and Takotsubo are more prominent in women. So if we look at valvular heart disease, we know that women have less calcification, not only in the vessels but also in the annulus in the heart itself, with comparable severity of aortic stenosis. And we know that women adapt better to aortic stenosis with their left ventricular remodeling than men do, so this is an advantage for women. And you can see that the transcatheter approach for aortic replacement is in fact better in females with less complications, but they may have more bleeding, but the prognosis is better in females compared to men. What should we do in cardiovascular disease? We need a lot of things. We need support from the government. And we just handed, in the Netherlands, we handed a report to our minister where we advised to do more, to get more money for research and also for female heart patients. We need more awareness programs for patients. There should also, other care workers in care, like nurses, should be more involved in gender differences in treatment and care. We need more interaction with gynecologists, rheumatologists, pulmonologists, etc. So many diseases overlap when we get older, and we need more better trials and statistical tools for gender-specific assessments, etc. And also in the guidelines, we now know that the guidelines In many cases, they lack any gender-specific recommendations, and in fact, in every guideline of the European Society of Cardiology and also in the US, the gender and sex issues should be taken into account.
Descriptive reports of gender differences in drug use are very frequent, but some of them are not true. Like the rumor that women have more side effects by statins. I thought so myself, because I have mostly women patients and they always complain about this. But we have scanned all the databases and the literature, and there is no evidence that women have more side effects from statins, like muscle pain and things like that. Sex can affect pharmacokinetics, pharmacodynamics, and side effects of drugs. Background to this website that we are, and the data bank that we are building, and it's called janusinfo.se.genus. And it's going to be in English totally in August. It's already now half in English, so you can read some of it in English also. And this is used by Swedish doctors and nurses who prescribing drugs.
Sex and gender actually may have some common mechanisms, since the biggest differences between women and men, these are the chromosomes. That's where we are all different, and these are the sex hormones. So maybe it's a more efficient approach that we start to analyze that some common mechanisms of sex and gender differences. And this was actually the approach in our workshop, and we tried to analyze some genetic and epigenetic mechanisms, genetic mechanisms X and Y chromosome, and then epigenetic mechanisms, modifications of genes by estrogens or testosterone that can lead to differences, role of sex hormones. We were interested in some translational approaches. Are there some possibilities to bring these basic research approaches into the clinic? It would be very interesting to know if protective effects are transmitted by a chromosome or by a sex hormone. And this can be done with very specific animal models. And I don't want to explain these animal models in detail, but I would just like to tell you that these models are feasible, but they are really a lot of work. And this is one reason that we do need funding for and calls for sex and gender research projects that develop such models and really go forward and ask for these models and support these models, because no one will just develop them if he does or she does not have money. To get some opinions on the floor. So would you tell us how long this window of opportunity, does it really exist?
Interesting new methodologies, always. There is no window of opportunity. I think the clinical trial regulation really has put into law the requirement to even more scrutinize the populations to be included in clinical trials. But we are very much interested in working with all of you in improving and developing tools to better generate or collect data, especially post-approval.
We do need not only to meet and to make good plans, but also to communicate. And I would like to give the opportunity to Marek Klesermann to tell us a little bit about opportunities that maybe that are important for him.
Well, I kind of indicated that this morning, this has been also come up again and again, that we are a small group of individuals interested in gender and sex-specific medicine, and there are probably more organizations than individuals in those organizations. And we have had too much time for that to talk, what are we actually teaching in gender and sex-specific medicine. Now, in my view, gender and sex-specific medicine is nothing more, nothing less than a quality improvement in medicine. That's what it is, actually. Our customers, somebody who should be involved in gender and sex-specific medicine is an academic, or even not necessarily, but let's say an academic individual who treats women and men. And this can be a doctor, this can be a nurse, this can be a psychologist, this can be a physiotherapist, and everybody. These should be our customers. And when Vera talked about this congress in Berlin, and we have to admit we have to struggle for congresses like that. Because there's so many possibilities to go to congresses, we could all start working and go from one meeting to the other. But we should regard this as a central effort to reach as many as possible really stakeholders. And stakeholders, it's easy to convince, are not only students and residents,